Thanks, Kit. Thanks for the opportunity again to sponsor your exciting event tonight. And I imagine that the Zoom meeting is completely full tonight and we can't go out 10-pin bowling or anything for another 24 hours. So it's a good night to be indoors and at another Zoom meeting. Thanks for the opportunity again to sponsor. A little bit about me. I've been with the MIGA for 10 years now, and hopefully I know a little bit about indemnity insurance. Hopefully almost as much as you guys will know about medicine by the time you've been doing it for 10 years. So yeah, it's amazing how much you learn the longer you do something. At MIGA, we've been around for 120 years, started by doctors, and you'll note that there's doctors on the board of directors. And another thing you'll note by the time that you have to start paying for insurance is that you guys are a member of MIGA. It's a member-owned organisation, and two of the insurers nearly merged about 6 years ago. And what actually happened was that the medical students in WA pretty much voted it down. So you guys have got power that you probably didn't know you had. So it is amazing to know that these are member-owned organisations that exist just for you. Now, before I worked here, I worked 10 years at Victoria Teachers Credit Union, and that's also a not-for-profit and member-owned organisation. So when I was looking around for a new job at that time, this is what I wanted, a not-for-profit that existed just for the benefit of the members, and that's why I'm here. So it's good to cover that off, because I think when I meet a lot of people at events, put on coffee for doctors, I think there's a feeling that the doctors think this is a profit-driven exercise, some of them. So it's good to get that across, that the only reason we're here is for your benefit. Now, being a not-for-profit enables us to give you a lot of benefits that probably a profit-driven organisation wouldn't be able to. We have a world's best risk management program, which once you're a doctor and you're not in exam time, you could do our online learning to avoid getting claims. It's certainly very well regarded worldwide, and the system, if you do it each year, also gives you a 10% discount on your premium on the following year. So that's something that we're able to offer because we're a not-for-profit, this online learning. Or you can come to a yearly conference in Melbourne. The next one's in January, I think, or February. Now, the other thing that comes from being a not-for-profit is the medico-legal support. So we've got a lawyer on call for you 24/7. I think we employ about 10 lawyers full-time, and that's something that we wouldn't be able to offer if we were a profit-driven organisation. Could you imagine CGU or someone employing 10 lawyers on call 24/7 to help just in a niche area of medical indemnity insurance? It just wouldn't happen. So it's an amazing benefit, and probably undervalued by students and junior doctors, because your insurance is free at that stage, and people don't understand, this doesn't happen in other industries, that you can ring up and just speak to a lawyer any time of the day or night to get advice, and someone who's just on your side. So to give you an example, maybe Gina Reinhardt is someone else that has a lawyer on call 24/7, but she pays $10 million a year for it, and you guys get it included in a free indemnity student policy. Now, the other thing that we're able to do is give you free insurance, and it's a very good policy. For instance, I think we're the only ones that cover you if you do an elective in the USA, which probably isn't happening in the next year or two, but it gives you an example how strong our policy is. You've got cover for rounds, you've got cover for Good Samaritan Acts, and a range of matters that happen to medical students, complaints to the medical board. And as you move into being a doctor, this policy that you get for free is still free until halfway through HMO3, and the policy at that point is just as good a policy that a staff specialist is paying $950 a year for. But we give it to you for free in the junior years, because we hope that you appreciate how good it is to have this product for free, and in the hope that you'll stay with us throughout your career. And I guess we'll make it up from you over the next 40 years, but in the junior years, even under that policy as a HMO2, while it's free, you can do unlimited private surgical assist or other private work. So outside of your normal training work. So to consider the policy still free at that point is amazing. Now, just to finish up with, we've got a partnership with Qantas for frequent flyer points. I've just been on the phone to our HMO3s telling them they get 20,000 Qantas points if they pay us this year, which is like a free flight interstate. Now, you guys as medical students can, if you join us for free, can also get a free Qantas frequent flyer membership in the meantime. That's valued at $99.50, and then you can start earning points if you shop at Woolies, and then by the time you get to HMO3 and we give you a lump sum of points, hopefully at that point you'll already have some built up of your own to be able to get slightly further with the points that we give you. So thanks for your time tonight. Use the QR code there to join if you're not already a member, and we'll see you soon. Thanks very much. Bye, everybody.
Thank you so much, David, for your time.
Thanks so much. Bye.
Okay, now we'll move on to our talk. So today's talk will be basically covering the B of breathing, which you see in resuscitation. The talk will be given, if you guys were here last week for our airways talk, by Dr. Bridget Bishop. She's currently a third-year anaesthetics registrar at Northwest Training and currently at Mercy Hospital. She also loves her dog, Lucy, who's a Labradoodle, very cute. And now, Lucy, I'll give it to you. Thank you so much on behalf of the audience and PVACCS for joining us today.
Thanks for that, Nam. I'm afraid Lucy won't be joining us tonight. She's upstairs with my housemate having a cuddle, which is probably much more fun for her than being here. I will just share the slides of the talk for today. Great. So can you guys see that okay? Yeah. All right. Excellent. Let's get to it. So there's a Slido available here for questions and answers sort of section that will be at the end of the talk. So if you could submit your questions there, that'd be great. But this will be an interactive session. So I'd really appreciate it if when I sort of throw a question to the crowd, you could either unmute yourself and answer, or if you're a bit shy, you can also feel free to put it in the chat as well. And I'll make sure I can get the chat available up in front of me where I can see it as well. So we're going to go through the assessment of breathing. We'll go through some common causes of impaired oxygenation and ventilation. We'll cover some really basic respiratory physiology and then methods of delivering oxygen to patients. And then the interactive part will be in particular the cases. We've got 2 cases to go through. So can anyone please share with me an approach to assessing a patient's breathing? What are we going to be looking or listening for?
I guess the first thing would be their rate and any noises.
Yep, so respiratory rate, and see if we can hear any noises. So that might be stridor, which would indicate an airway problem, or wheeze. We've got character of breathing, which I guess could reflect the work of breathing. So they're using any accessory muscle use, the rise of the chest. So yeah, how their chest wall is moving. What else can we look at? Maybe another observation in addition to respiratory rate. Saturations, yeah, great. So this is a handy mnemonic for remembering how to assess a patient's breathing. It's rates, starting with the respiratory rate, auscultating, so we're listening to those sounds, looking at the trachea to see if it is midline or not. What would a non-midline trachea indicate?
Tension pneumo.
Yeah, pneumothorax, great. We've got work of breathing and saturations. We can also have a look at the patient's blood gas, which we won't go into in too much detail, but we will touch on shortly. Great, so that leads in quite nicely to the assessment that we talked about for airway last week. All right, so what are some common causes of impaired ventilation in a patient? So, because I guess when you think of breathing, we can divide it into oxygenation and ventilation. So getting the air into the lungs and then the gas exchange across the alveolar units. So what are some common causes of impaired ventilation?
Maybe like a chest wall injury.
Yeah, great. So we can consider the chest wall as a unit. So injury, or even just pain from, say, rib fractures. There can also be pathology of the chest wall, or even abnormalities like scoliosis and kyphosis. Yep, so that's the chest wall. What else?
Airway blockage.
Yep, so airway obstruction, which we would have covered last week. Yep. All right, well, what about some of the causes of impaired oxygenation? So impaired gas exchange at the alveolar level, what are some causes of that?
So we could have poor perfusion to the lungs, or an increase in the fluids, so it's part of a effusion.
Yep. So we can have pleural problems, like a pleural effusion. Within that, we'd have hemothorax and pneumothorax as well. You mentioned perfusion. So yeah, we actually need to have blood flow to the lungs in order for gas exchange to occur. We've got some airway problems like asthma, COPD, consolidation. So that could be pneumonia, interstitial lung disease, and that's quite an extensive list. So I've summarized those causes here by breaking it down into impaired ventilation and impaired oxygenation, and I think we did pretty well. So just to recap, impaired ventilation, that could be a respiratory drive problem, a chest wall problem, or a problem with the lungs themselves in terms of their ability to ventilate. And then of course there's impaired oxygenation, so airway obstruction, and then the respiratory pathology that could be at the level of the pleura, the airways, the alveoli, or the pulmonary blood flow. So lots of causes for impaired breathing. So quite an extensive list there. All right. So we're just going to cover some basic respiratory physiology now, starting off with the types of respiratory failure, which leads in quite nicely to this. So we might remember that type 1 respiratory failure is impaired oxygenation with normal ventilation. So what we see in those patients is that the oxygen level is low on the blood gas, but the carbon dioxide level is normal. So that would be a type 1 respiratory failure. And so we might see that in an asthma attack, for instance, in its early phases. Type 2 respiratory failure is the impaired oxygenation, as in type 1, as well as impaired ventilation. So we might see that carbon dioxide starting to rise. And, you know, again, typically we might see that in this as an asthma attack continues and becomes quite severe. So that's an important distinction, and they're just terms that we use when communicating with one another. For example, with anesthetics ringing ICU, I have a patient with type 2 respiratory failure, and that just very clearly communicates to them that it's an oxygenation and a ventilation problem. Another bit of respiratory physiology that I wanted to briefly cover without boring you guys too much is VQ and VQ mismatch. I just wanted to cover it because I think it's terms that are thrown around quite a lot, but are maybe poorly understood. And if I'm going to be honest, it wasn't until I did my primary exam for the anaesthetic training that I really sort of understood it. But it really is quite a simple concept. So V and Q, well, V means ventilation and Q means perfusion. So the VQ ratio is just the ratio of ventilation compared to perfusion. It reflects how well alveolar ventilation matches capillary perfusion. And I just wanted to highlight that on average, a normal VQ ratio in a patient or any person is 0.8. A VQ ratio within the lungs can vary whether you're in the apex or in the bases. So as you can imagine, in the bases of the lungs, in an erect person, the blood flow at the bases is going to exceed the ventilation. So that's going to be quite a low VQ ratio, whereas at the apices, the ventilation is going to exceed the perfusion, which would result in a high VQ ratio. So to say that there's VQ mismatch is a very imprecise term, because VQ is rarely exactly 1. And there is a variation of ventilation and perfusion within the lungs that is normal. So why do we learn about VQ matching or mismatching? Well, it's because it's the extremes that matter. So shunt is VQ of 0, and that's where, and I think the definition of shunt that I find useful is the proportion of the cardiac output that doesn't participate in gas exchange. So it's alveolar units that are perfused and not ventilated. So a classic example of this is atelectasis, where you've got lung collapse, and those alveolar units are getting blood flow, but there's no air going in. At the other end of the spectrum, we've got dead space, where VQ is infinite. And dead space is a proportion of the tidal volume that doesn't participate in gas exchange. So these alveolar units are ventilated and not perfused. And that's a very simple explanation as to how a pulmonary embolism can cause hypoxia through affecting perfusion, but not ventilation. I wouldn't stress too much about remembering the details of this as a medical student at all. I just wanted to include it because I think, again, just the term VQ mismatch is thrown around and maybe not, you know, all that accurate. And so if we can just remember that it's normal for VQ to vary within the lungs, what the spectrum of normal is, and how we've got extremes at one end with shunt, where we've got perfusion but no ventilation, and dead space where we've got ventilation and no perfusion. I'll stop boring you to death with that stuff. And let's actually go into some really practical things that I think are going to be useful for you guys as junior doctors, and that's ways that we can deliver oxygen. So when we're delivering oxygen to a patient, most of the simple devices do depend on the patient being able to breathe for themselves, right? Because we're not actually ventilating them, we're just going to be oxygenating them. There are different types of devices that we can see. So nasal prongs, Hudson mask, non-rebreather. What would the maximum FiO2 of nasal prongs be, do you guys think? Because obviously the nasal prongs are going to be attached to 100% oxygen coming out of the wall and into those tubes, but it's not 100% oxygen that's going into the patient's alveoli. So what do we think is going on there? Someone has said about 28%. Yeah, that's about right. Like, it's not excellent. So when the patient breathes in, they breathe in some of that 100% oxygen that's coming up through the nasal prongs, but they're also breathing in room air that is diluting that. Now, nasal prongs you can use at flows of 1 to 4 litres per minute, and anything more than that's going to get pretty uncomfortable. And as you can imagine, nasal prongs really dry out the mucosa of the airway. So, you know, they're good for delivering low levels of oxygen. What about a Hudson mask? How much oxygen do we think we can deliver with that? How much does the patient get? Someone said about 60%, 40%. I would say that it's probably more around 40%. And again, if we just look at this next picture here, where we can see that the Hudson mask, which is on the left, has got holes in it. It's not a perfect seal. That's where all that room air can get in. So it's probably about up to 40%. And we can use Hudson masks with up to about 10 litres of flow. Can anyone explain to me what a non-rebreather mask is? That's the one that's on the right.
It creates like an oxygen reservoir. The bag, you sort of inflate it with the oxygen coming out of the wall. And so when you breathe in, you get sort of more oxygen.
Yeah, exactly. So, you know how I mentioned with the nasal prongs and the Hudson mask, that when the patient breathes in, they get some room air in to dilute that mixture. The non-rebreather is really helpful because it's got the reservoir bag that will have 100% oxygen going into it. And it's from that reservoir that when the patient breathes in, they can get 100% oxygen. They also get it from the tubing itself. There's also some valves that you can see there too, which prevent entraining of room air. So you can deliver up to about 80% oxygen with those, and you can use them up to about 15 litres. So my main message with all of these oxygen delivery devices is really that the non-rebreather mask should be your go-to in an emergency where you have to deliver high concentration of oxygen fast. Okay, a non-rebreather is gonna save you in those situations because you can deliver up to 80%. This picture here just rounds out some of those devices. We've obviously talked about a couple of those. A Can anyone, so we've obviously identified that C is our nasal prongs, B is our Hudson mask, and E is our non-rebreather. What's A? Does anyone know what A is? Venturi's, yeah. So that is a Venturi mask. So they're not really used all that much anymore, but essentially those colored devices there have got different apertures of different sizes that allows a different amount of room air in. And essentially, long story short, you can be pretty confident with, pardon me, how much oxygen you can deliver to the patient. So it's useful for when you want to do a blood gas and know for sure what the patient's FiO2 is. But certainly I can't say I've seen them much in my practice. What about D? What's that? High flow nasal prongs, great. So these we can deliver up to 50 or 60 litres a minute, so orders of magnitude higher than our other devices. They're useful because they can be humidified, so they can deliver humidified air, which is nice for the patient's nasal mucosa. And also for every 10 litres a minute of flow, you can get 1 centimetre of water of PEEP, which is a positive pressure that will help keep airways open. So they're, they actually can help a little bit with ventilation as well, and are a way of delivering a cracking amount of oxygen. So they're really quite useful and becoming more and more popular in hospital. Has anyone got any, actually maybe we'll save the questions to the end. I was just about to ask if you had questions, we'll save them to the end and we'll move on just to round out our oxygen delivery devices before we go on to our cases. So remember how I said that those oxygen delivery devices depend on the patient being able to breathe for themselves? Well, these devices actually allow you to ventilate the patient as well. So deliver positive pressure ventilation, and that's a bag valve mask, which you see there at the top. And there's also non-invasive ventilation, which is attached to a ventilator through a mask. We've also got some information here about ventilators, but again, I think that's probably getting a little bit too beyond the scope of this talk, except just to know that normal respiration is negative pressure on breathing in and atmospheric or positive pressure on breathing out, whereas when we are ventilating somebody, it's all positive pressure. So it's sort of opposite. Great. Let's get into some interesting cases. We've got 2 cases to go through. Case number 1 is we've got a 65-year-old man with 3 days of increased shortness of breath, productive cough, and rigors, and he's got a history of COPD. His other history includes hypertension and diabetes, and he is a smoker. This is his examination findings. So we see he's tachycardic, tachypnic, hypoxic, and febrile. And if we go through our rates assessment, we can see that our rate is high. We auscultate and we can hear crackles and wheeze. His trachea will be midline. He's speaking in short sentences and has intercostal recession. That's going to be an increased effort of breathing, and our saturations of low. So how would we assess and manage this patient? I see that someone has commented to get this man a COVID swab, and I certainly don't think that is unreasonable in these times. But if you can cast your mind back to a pre-COVID world, what else do we think might be going on?
Infective exacerbation of COPD.
Yeah, that's a classic one, isn't it? Yeah. So he's got baseline lung disease that has probably gotten worse in the setting of infection. So we need to manage him from a breathing perspective and from an infective exacerbation of COPD perspective. So we're going to get our trusty non-rebreather mask and get him onto some oxygen, aiming for saturations of 90% thereabouts. And then that's treating the breathing side of things. And then we'll give some bronchodilators as well to help with that, and then treat the infection with antibiotics. So there's a common sort of, I guess maybe misconception or common teaching about oxygen and CO2 retainers. So first of all, what is a CO2 retainer? What does that mean?
Does it mean that they've just gotten so used to having higher CO2 levels?
Yeah, so a person that retains CO2 is somebody that has a lung disease that impairs their ventilation chronically. So they've got chronic respiratory failure, and therefore their CO2 levels are higher than normal. And then the theoretical physiological effect of that is that it affects their respiratory drive. And of course, we didn't actually cover this in our physiology section, but respiratory drive in normal people is predominantly driven by high CO2. And that's quite a strong signal. So it's why when you hold your breath that you eventually have to give up. And then low oxygen is a secondary stimulation of respiratory drive. So the concern in patients that retain CO2 is that their respiratory drive becomes more dependent on hypoxia. So the theoretical concern would be in a CO2 retainer, you put too much oxygen on them and then they become, apneic because they've lost that hypoxic stimulation for their respiratory drive. I guess just two things to comment on that. Number one, to diagnose a CO2 retainer, you have to have old blood gases to see what their CO2 is at baseline. And another clue to that is their bicarbonate. And again, without going too much into respiratory physiology and acid-base stuff, but as you can imagine, as a patient's carbon dioxide becomes chronically high, they're going to have a chronically high bicarbonate in the order of 30 to offset that so they can maintain a normal pH. So if the patient is a CO2 retainer, you might see a bicarbonate in the order of 30 on a baseline gas, or even higher, and you should see higher CO2 in a baseline gas as well. So step one with COPD patients is identifying whether or not they're CO2 retainers, number one. And number two, when it comes to critical hypoxia, SATs of less than 80, just get the oxygen on and worry about that stuff later. You're not going to harm the patient by, causing them to become apneic from too much oxygen. You will harm them by not giving them oxygen. So, and we would aim for a SATs of about 90% to account for that sort of CO2 retention thing. Okay, so don't be afraid to give oxygen to patients with COPD. That would be my main message. Great. And again, I've got a funny story about that, but maybe I'll save it for later. All right, let's move on to our second case. We've got a 78-year-old female brought in by ambulance with shortness of breath, which has been increasing over the past month. She's from a retirement village, and staff have noticed that she's starting to sleep on 3 or 4 pillows at night. So that might be orthopnea. She has a history of severe aortic stenosis and is due for a valve replacement, which was cancelled last week because of lockdown. So we see that on examination, she's tachypnic, got there, and hypoxic. We see that she's got increased work of breathing, she's got crackles and pitting edema and a raised JVP. So what do we think is going on here? Fluid overload, what from? APO, yep, what from? Heart failure, yep, what from? Take all the steps back. She's got severe aortic stenosis, so she's probably got left ventricular hypertrophy from that, and something has caused her to decompensate. And with patients, with heart failure or, valvular heart disease, you've got to look for a reason as to why they've been tipped over the edge. But again, that's beyond the scope of this talk for today. But as you can see, we just need to take all of those steps. So we agree that she's fluid overloaded, probably has a degree of pulmonary edema and heart failure from aortic stenosis. So, oops. Assessment and management, we agree that she's going to have heart failure. So management will be treating the cause of her heart failure, whatever that is, and giving her furosemide to get the fluid off. Other management for acute pulmonary edema would include GTN and positive pressure ventilation through CPAP or non-invasive ventilation. There's sort of things we might be considering for this lady, and probably ultimately just needs her valve replaced. Great. So very physiologically dense talk there, I'm sorry. But I think understanding the basic principles behind a lot of the pathology can help you understand what's going on. So that finishes the formal part of the talk. I'll just throw it back over to Nam to go through some questions on the Slido.
So just in the chat, had a question by about, so what was it? Yes, is high flow nasal prong similar to CPAP?
No. So CPAP is a form of non-invasive ventilation, which is applied through a face mask, or it can be through a nasal device, and that's attached to a ventilator, which actually delivers positive pressure for the patient. CPAP is a continuous positive pressure, which an NIV machine could deliver. High flow nasal prongs are literally just the prongs and high flow being delivered. I guess there are similarities in that there's so much liters per second of oxygen being delivered that can cause a degree of positive pressure, which is useful to help keep the airways open in terms of positive end expiratory pressure, which is same but different to CPAP. And again, I won't go into that in too much detail.
On the thing of detail, someone's just asked, what's the difference between BiPAP and CPAP, and are they the same thing?
They're not the same thing. CPAP's pressure is continuous. BiPAP, you dial up an inspiratory and expiratory pressure.
Sort of what would be, just a question from me, what would be the indications you would progress a patient to NIV as opposed to doing the other stuff like intubation or just like the non-rebreather and stuff, or EVO?
Yeah, so I guess in an acute situation, part of the decision-making process is what is the patient suitable for in terms of ceiling of care. And if you're going to acutely start NIV in a patient, they will have to either go to a respiratory high dependency unit or an intensive care. So you'd be referring to those people, I guess, for permission, because they need to be admitted to those areas. So you need to confirm that that's appropriate for the patient. In terms of deciding whether or not you need it or not, it all is on a spectrum. So nasal prongs, Hudson mask, non-rebreather mask, high flow nasal prongs, they're all useful if the patient has just got a sort of oxygenation problem rather than a ventilation problem. So that's your sort of more of your type 1 respiratory failure situations, because they're just providing oxygen, whereas non-invasive ventilation and intubation and ventilation all provide ventilation support, which is useful for type 2 respiratory failure. So you'd be guided by the pathology. So is this something that's going to get better quickly and the patient will catch up with their own ventilation themselves? And, you know, or is this going to be a ventilation problem that needs ongoing support? And you can look at their blood gases to help make those decisions. So that kind of, without going into too much detail, I hope that answers the question.
Someone's just asked, do you always just use 100% oxygen in met calls through like a Hudson mask or nasal prongs because it's an emergency, or should you titrate to the SATs?
So just to be clear, like when you're whacking nasal prongs or a Hudson mask or anything onto the oxygen at the wall, that is 100% that is going into the tubing, and all that you're changing is the amount of flow that's coming out. So with nasal prongs, you can only dial up to 4 liters a minute on the dial. Hudson mask can get up to like 10, maybe 15, and then a non-rebreather you can get up to 15. And it's that flow of 100% oxygen combined with the device that you're using that will determine how much of that 100% the patient is giving. So yes, you're always just going to be putting it onto the 100% oxygen that's coming out of the wall and dialing up. And but I guess to sort of answer the question in a way, yeah, you're going to just put it on, crank it up, and then dial back. That's probably the safest thing to do. And dial back and titrate to SATs of 90% thereabouts. The exception to that is high flow nasal prongs, which blend oxygen and air. and the nurses can help change what those dials are in a situation if needed to. Yeah, if I may, there's a good question in the chat on Zoom about what non-invasive ventilation actually means, and they're absolutely right. It's basically ventilation that is positive pressure ventilation through a mask. Invasive ventilation requires an airway device to be placed. So that is either a laryngeal mask airway or an endotracheal tube or a tracheostomy or something like that. So that's invasive, whereas non-invasive is a mask.
Perfect. That's essentially all the questions we have for now.
Can I tell you a funny story?
Yes, we have time, you may.
I went to a Met call for hypoxia in a patient that had COPD, and someone had put a non-rebreather mask on, which was excellent. However, it was attached to the air port of the gases on the wall, because the nurse was just very diligent about not giving 100% oxygen to a patient with COPD. So my management at the Met call was mainly just to swap the tubing over onto the oxygen and going from there. So yeah, that gave me a bit of a chuckle.
That's a good story. So it was basically just, they did nothing for him.
Oh, look, they were well-intentioned.
Yes, exactly. Totally understand.
Yeah.
Amazing. Thank you so much for your talk on behalf of the audience and PVACCS. It was really great to have you talk about airways and breathing. I learned heaps from you. Yeah, I guess just for everyone else, the event, will be recorded and it will be posted on our YouTube page, on the PVACCS Facebook page as well. And I'd encourage everyone to sort of sign up so you can be linked into our future events. We'll be having talks on circulation, disability and delirium, as well as pain later on in the year, as well as a careers night. So stay tuned, guys. Thank you all for coming. And thank you, Bridget.
No worries.
Thanks, Bridget.